Hello, my name is Dr. Samantha Curray. I'm an academic clinical fellow in paediatrics at the Great Ormond Street Institute of Child Health in London. And today I'm going to be presenting data on our UK DADA2 conference at Great Ormond Street Hospital, or GOSH for short. I work together with Professor Paul Brogan and Professor Despina Eleftheriou. So just to give you a brief overview, I'm going to talk a bit about our general patient characteristics, CNS and non-CNS ischemic events in our cohort, hematological phenotypes, anti-TNF treatment and outcomes, summary and conclusions, limitations, and future work. So 31 patients were seen by our paediatric autoinflammation team at Great Ormond Street Hospital, which is a quaternary referral centre for DADA2 in the UK and aids the diagnosis of DADA2 because it offers genetic screening and serum testing of ADA2 enzyme levels. All patients presented in this talk had confirmed biallelic or compound heterozygous mutations in the ADA gene and either reduced or absent ADA2 enzyme levels. There are 14 females and 17 males with a median age of 15 years, the youngest being 3 years and the oldest being 39 years of age. 9 of our patients have already transitioned to adult medical care. The median age of disease onset was 5 years, with a range of 2.5 months to 17 years. This table shows the first half of our patient cohort in terms of genotype-phenotype correlation, and siblings are indicated by a star and a S1, S2, etc. in the very left-hand column. The main point I wanted to make about this first table was that the genotype-phenotype does not necessarily correlate amongst patients and even amongst sibling pairs or sibling groups, some of which can present with very mild disease and some with a more severe phenotype, including lacuna stroke. Patients with severe hematological manifestations are highlighted in bold, for example, patient 3 who presented with complete bone marrow failure. The 3 siblings at the bottom of the table have a unique phenotype with upper motor neuron signs that does not seem to be related to acute vasculitic events. This is a continuation of the table and shows the second set of our 31 patient cohort. And amongst these are some of the older patients. And you can see that many of them had their first presentation of lacuna stroke. And there are another 2 patients noted here with severe hematological manifestations. In terms of ischemic events in our patient cohort, 26 out of 31 patients had 1 or more ischemic event prior to treatment with anti-TNF. There were 38 CNS events in 18 patients, including 7 hemorrhagic strokes, an example of which is shown on the right and has been previously published by our group. There were 30 lacuna strokes and 1 right MCA infarct. There are also 15 non-CNS ischemic events in 9 patients, including digital necrosis, peripheral limb ischemia, bowel ischemia, testicular infarct, and renal ischemia. 4 of our patients had inflammation, but no ischemic events. And 1 patient, unfortunately, with complete bone marrow failure and gut ischemia, died of bowel perforation and sepsis shortly after diagnosis. and prior to planned anti-TNF treatment and HSCT. The median time from symptom onset to starting anti-TNF treatment was 73 months, with a range of 2 to 240 months. It was longer for older patients due to anti-TNF treatment being historically unavailable. But as diagnosis and recognition has improved in the UK, the time to treatment has become shorter. 27 of our patients received anti-TNF treatment for a median duration of 32 months. The median is quite low because some of our patients in the cohort are quite young and have only just started treatment. 3 of the patients had very mild disease, presenting with just livedo reticularis or racemosa, and did not require treatment. And as I mentioned, 1 patient sadly died. Of those on anti-TNF treatment, 20 receive adalimumab, 6 etanercept, and 1 is on infliximab. 4 had infusion reactions to infliximab and was switched to adalimumab. And 1 patient was switched from infliximab to etanercept after a treatment break. We monitored the effect of anti-TNF treatment first by evaluating the Pediatric Vasculitis Activity Scores, or PVAS. These were calculated at first symptom presentation, prior to anti-TNF treatment, and then at most recent clinic visit after starting anti-TNF treatment. And what we found was there was a very significant reduction in PVAS score from a median of 20 out of 63 to a median of 2 out of 63 following anti-TNF treatment. We also looked at the ischemic event rate. So in our cohort, there was a total of 53 ischemic events over a cumulative total of 2,324 patient months. This reduced to 4 ischemic events over a cumulative total of 1,325 patient months. And calculating the median rate of ischemic events per 100 patient months, this reduced from a rate of 2.37 to 0, which was statistically significant. And this can be also represented graphically, and you can see the significant reduction in the ischemic event rate. 1 patient had quite a high ischemic event rate of 50, and this is because they had several ischemic events in a very short period of time, but were diagnosed rapidly and instituted on anti-TNF treatment within 2 months. We also looked at the reduction of inflammatory markers following anti-TNF treatment in our cohort, and found that there was also a significant reduction in CRP and ESR. 1 patient with neutropenia and recurrent infection had unfortunately persistently high inflammatory markers irrespective of anti-TNF. This figure just shows a patient with peripheral vascular disease and a chronic non-healing vasculitic ulcer. And following TNF treatment, this showed complete resolution after 4 months of anti-TNF. In terms of our hematological phenotypes, we found that anti-TNF treatment had no impact on hematological abnormalities in our patient cohort, in common with previous studies. 4 patients had severe hematological abnormalities. 1 had thrombocytopenia, neutropenia, and anemia requiring GCSF, which was still required post anti-TNF treatment to maintain neutrophil levels, although the thrombocytopenia and anemia resolved. 2 patients had multilineage bone marrow failure requiring regular GCSF and blood products, One underwent allogeneic HSCT and subsequent splenectomy, following which cell counts normalized and steroids, azathioprine and anti-TNF were stopped. The other patient died prior to planned allo-HSCT, as mentioned previously. The fourth patient had severe isolated neutropenia with recurrent infections and requires GCSF infusions. This patient is being worked up for allo-HSCT at present. In summary, of the 31 DARDA2 patients in our UK cohort, 3 remain well, having never required treatment. 26 patients remain on anti-TNF. 1 patient has had allo-HSCT and stopped treatment, and 1 patient died. Anti-TNF treatment significantly reduced both CNS and non-CNS ischemic events in our cohort of DARDA2 patients, and reduced vasculitic disease activity and inflammatory markers. This supports previous findings of stroke reduction by Ombrello et al. In 2019. We found that anti-TNF treatments were well tolerated, but mild features such as livedo racemosa or reticularis and headaches persisted in some patients. Anti-TNF treatment is not effective for the treatment of severe hematological abnormalities, allo-HSCT being the only definitive treatment for non-infarctive bone marrow sequelae at this time. Unfortunately, anti-TNF treatment is not yet routinely available in the United Kingdom via the NHS for DARDA2. We hope that the current work will influence policy and decision-making to make anti-TNF treatment more widely available for these patients. HSCT for hematological manifestations of DARDA2 is not without its risks, such as graft versus host disease, infection, and engraftment failure. And there's also been concern over the longer term use of anti-TNF agents with the development of anti-drug antibodies in older patients, limiting effectiveness. We did not measure anti-drug antibodies in our cohort, but we suspect they may play a role because in some of the older patients, we are starting to see reduced efficacy and the need for additional steroids or other DMARDs to reduce inflammation. Gene therapy offers a potential curative option and is actively being studied by our group for this monogenic disease. It has proved successful for other monogenic diseases, including severe combined immunodeficiency caused by mutations in ADA1, ADA SCID. Thank you very much for your time.